Reduce. So the Georgia Memory Nets, as we said, are clinics that can diagnose why people are having symptoms of dementia or memory problems and other symptoms. And I'm sorry, there was a little notice on my screen that we were being recorded. So after the 2 appointments that you have at the Memory Net, you will have an intense session with a community educator who's a clinician, a social worker. And the social worker will go over a lot of education, sort of the 101 of dementia, and let you know about the healthy lifestyle interventions, talk to you about resources in the community, and provide you with referrals, 2 of which are to the Area Agency on Aging, and the other one is to the Alzheimer's Association. So wraparound care is the opposite of you have Alzheimer's, come back in 6 months. Wraparound care is, it's person centered, right? That's the word that we use in the business a lot, right, Dr. Parker? It's person centered. You're going to get some time, and very significantly includes the care partner. Alzheimer's and other related dementias really require a care partner to come to appointments to understand and to assist, maybe not physically, but just to help with the management of the disease. And it's just, it makes the difference, I believe, in a quality of life for someone who is living with a diagnosis. The Alzheimer's Association then introduces those people to our programs and services, which include a good deal of education. We are all about education in many forms. We have been virtual, of course, since the beginning of COVID, but are taking steps to get back to in person slowly and incrementally, but surely. And we're very happy about that. But we will probably retain some of the virtual programs and offerings because we find that it's very convenient for people. And like this, it's just a great way to get together with others and learn together. We have 4 core education programs: Understanding Alzheimer's and Dementia, Healthy Living, which focuses again on the healthy living lifestyle interventions that can reduce risk and hopefully preserve cognitive reserve. We also have a program about the 10 signs. So we're about all people, people that want to maintain their health and learn more about brain health so that they can reduce their risk. We're about helping care partners understand and help their loved ones who have a diagnosis. And we're also about working with folks that are living with dementia. So we even have a pretty large early stage program. I am the helpline and the early stage program manager, and I manage a program that it consists of about 25, sometimes a little more, sometimes less, virtual programs per month for folks who are in mild cognitive impairment or early stage and their care partners. That program is focused on the domains that match the healthy lifestyle interventions. So we have that. And then we have the helpline, which is an incredible resource. It's a 24/7 free service staffed by clinicians. And I'll be happy to give you that number. I've certainly got it memorized, but it is 800-272-3900. That is our 800 number. We have an office in Atlanta, and then we have an office in Columbus, in Macon, in Augusta, in Dalton, Georgia, in the northwest corner, and then down in Savannah in the coastal region. So we're really covering Georgia, and I think that's a good rundown of everything that we do. I'm sure I've missed something because we do quite a bit. Oh, the big thing that we do. Oh my gosh, Dr. Parker, don't get on to me. We fund research. We fund a lot of research. That is, the Alzheimer's Association is about eliminating Alzheimer's and related dementias. But in the meantime, we are about funding research that will lead to the drugs and interventions that will eliminate dementia, we are all hoping. And until then, making the quality of life for those living with dementia and their care partners a high quality of life, as high as we possibly can. So I think more than anything, we're a community. And I would just like to say, because I run across lots of people that are not aware of this, Georgia, if one has to live through a diagnosis dementia, Georgia, and especially our area here, is a good place to do that. We really do have many resources here in our state, and I'm proud of that.
Okay,
Thank you so much.
Go on. Cornelya.
Well, just a fun fact is that in the general public, we know you as the Alzheimer's Association. However, what is the accurate title of the organization?
The Alzheimer's Association Georgia chapter. That is the title of our organization.
Mhm. Well,
Am I
one thing that
correct there? But I know I'm working for the right. That's who pays me, folks.
well, Miss, I think it was Miss Davis or maybe Jill. Jill, I think, told us like, oh, it says Alzheimer's in the title, but our name is Alzheimer's and Related Dementia Association.
Oh,
So it was
right,
this long
The
title, and it's like,
Alzheimer's Association and other related dementias, but
yes.
yes.
And so I think people will believe that, oh, you're only targeting Alzheimer's. However, that's not the case.
That is not the case. Any form of dementia or memory impairment, actually. And thankfully, we're seeing more and more people diagnosed earlier and earlier, which is what we want, right, Dr. Parker? We want people diagnosed early. Early detection in any chronic disease is just so important.
Absolutely. So now we are going to transition over to, will you put the phone number in the chat? We do have several listeners who are vigorously taking notes. So Mrs. Caldwell is going to put that in the chat for you all.
Thank you. Thank you for having me. It's been a pleasure to come today.
Thank you. Okay, so Dr. Parker, last week we talked about the big news, as you can imagine. And so today we wanted to clarify for viewers and listeners, there's all types of behaviors that people will witness for those experiencing memory-related issues, but there's certain medications as well. And as we are seeing this new drug come online, we want to give people just a one-on-one about these dementia behaviors and medications.
Okay, great. I want to start. Dr. Trammell is off the phone, but I wanted to say thank you to Dr. Trammell, who is a very active clinician. He's based primarily in the Grady Health System. Okay, he's an Emory faculty member, but within Emory, we have all kinds of things. So the Grady Health Center has a memory center where these evaluations can take place. And because Dr. Levy, Dr. Law, Dr. Ted Johnson, and geriatrics and myself were some of the key physicians involved in the development of the Georgia Memory Net, I need you to understand that the Georgia Memory Net was founded and developed consistent with the need for making it possible for people across the state of Georgia to have the same kind of evaluation that would be done here at Emory in the cognitive neurology department in other places. The Georgia Memory Net centers for diagnosis and evaluation of patients with this disorder, these disorders, I should say, are located in centers where there is a medical training program, usually the family medicine training program, anywhere where there are medical residents. So in Augusta, it's with Augusta University, which used to be called the Medical College of Georgia. In Columbus, it's at the Columbus Family Medicine program. In Macon, it's through Navicent Healthcare, and I think they've changed their name, but it's being run through the Department of Family and Community Medicine. And in Albany, the Memory Assessment Center is run out of Phoebe Putney Hospital, which has a training program for family medicine doctors that are generally coming out of the Georgia medical school system. So just want to get those little factoids in there. All of the memory assessment centers here in Georgia are associated with a medical training facility such that doctors who are going out into practice are aware of how best to evaluate and manage patients with Alzheimer's and/or related dementias. So with that, we'll go on into my brief PowerPoint to kind of help you understand a little bit more about some of the behaviors that go on with people who have dementia. So for this slide, I just want you to understand that when people have a diagnosis of dementia, whether it's Alzheimer's or any other type of dementia, there may be behaviors that go along with it. The problem with caregiving is that we don't frequently know how to best manage those behaviors. And we think by just talking to the people like we would have if they were 20 years earlier, that they would come to see reason. As a primary care clinician and as a family caregiver, I need to let you know that that's impossible. You are never going to be in the head of somebody who has dementia and make them see things your way. It's just not going to work. And so because people with dementia have a different way of communicating and behaving, we need to be able to identify what some of those behaviors mean. Next, please. So what are some of the most commonly reported behaviors that we see in people who have dementia? Please note that any of these things that you observe in somebody who is a relative or somebody that you care about, if you don't know what's causing it, the thing to do is to get to a doctor. Most commonly reported symptoms are wandering, getting up and out of the house at hours when most people are asleep, repeating words, repeating stories, repeating statements. I wish she'd just shut up. She says the same thing over and over again. It just drives me crazy. Well, she can't control it, okay? Sleeplessness. My mother's up wandering the street, wandering the house when everybody else is asleep. And if she doesn't do this, if she doesn't stop this, we can't go to sleep. People with advanced dementia may develop a certain amount of paranoia or hallucinations. They may see people or hear people that really aren't there. And when you see that and you hear that, it's important to address that because that may indicate that that person's developed an infection of some sort. Irritability, lots of behavioral changes, personality changes where people with dementia become very irritable and maybe hit out at you and don't act politely in company. Urinating and defecating in all the wrong places. As a clinician, the most commonly encountered behaviors are number one, wandering, and number two, urinating and defecating in the wrong places. Some people have been put out of assisted living facilities because they've urinated on the furniture or they've repeatedly defecated in closets. That will even happen if they're in a home. And as we go along, one of the things I like to say is that when people have been in a home for 50 or 60 years and you take them out of that home and you put them someplace else, a lot of times, a lot of the reasons they wander is they're trying to get home to what's familiar. A lot of times they urinate and not in the bathroom is because they honestly don't know where the bathroom is. They're disoriented. So it has to be clear where the bathroom is so that they can find it on their own. But they also recognize that they're not in a familiar environment. So the inappropriate toileting is going on simply because people are lost within the building that they're in. Okay, their sense of reality is quite a bit different from anybody else's. Next, please. So what are some of the behaviors that we call disturbances of dementia? Non-psychotic agitation, that's walking back and forth. Some people walk round and round in a circle. When I went to the Netherlands to see the homes there, people were walking around and around. Nobody ever stopped them because they couldn't get out and couldn't get lost. Psychosis, being confused, that's the paranoia where you see people are talking about me, they're saying things about me, I'm seeing things that aren't there. Some people with dementia aren't sick, they're not hallucinating, they just may be extremely anxious, particularly when they're in situations where there are crowds or where there are people with whom they have no familiarity, which is a reason why not to have big parties and gatherings involving these people. People who have advanced dementia may exhibit signs and symptoms of depression, which we see manifest as apathy. They kind of withdraw. Early on in the disease, people who recognize that they're having trouble with remembering things don't generally want to leave the house or leave what's familiar. So they say, oh no, let me just stay here. So they become a little like hermits, and they may get a little depressed. Some people's behaviors are such that instead of being extremely anxious or being irritable, they become threatening or violent, particularly because they feel like they are threatened. And so they're trying to defend themselves. Next, please. What are some of the things that may cause somebody's behavior to be unusual? As I've talked about earlier, people who wander at night are generally trying to find their way home or find their way to something that's familiar. So that's why routines and keeping people in familiar environments are important, okay? Infection. If I have a urinary tract infection, or if I have a respiratory infection, I may become very irritable. I may be a little bit more lethargic. I may not be as organized as I usually am, despite my diminished state. Some people who have pain, because they can't explain to you where they have pain or why they have pain, will do something unusual. One of the things that one of my patients did who broke her fibula was she stopped walking. She stopped walking because it hurt her to walk. So rather than get up out of her chair, she just sat in the chair and she refused to get up and walk. And her family couldn't understand why she was refusing to walk. And when somebody tried to get her up to make her walk, she would hit out at them and strike out at them. And that was because she was trying to protect herself from getting more pain and didn't necessarily want you to bother that part of her leg that was painful to her. Because they can't use their words, they respond in other ways. Sometimes when people are confused, they're agitated, or they're anxious, particularly when you take them out of their familiar environment and put them someplace where they are unfamiliar, they may not sleep well. They don't sleep well because they don't recognize the room they're in, and it's a foreign place, so they're going to get up, try to walk away, and get to where they think they're familiar. Some people who have dementia don't recognize that they're hungry, so they don't eat a lot and they don't drink a lot. And as a result of that, they may develop a lot of weight loss, may develop protein malnutrition. They may even become dehydrated, which leads to more confusing and disturbing behaviors. Next. So how do you behave? How do you manage these behaviors? You know, decades ago, we used to try to control these behaviors with medicine. But as research has progressed and we've learned more about these behaviors, we find that there are things that you can do that don't involve medicines to control their behaviors. What are some of the medicines that we use? Next slide, please. Some of the medications that we use to treat anybody with usually Alzheimer's, but any type of dementia, you're going to hear these names. There's something called cholinesterase inhibitors, that's Aricept, that's Exelon, that's galantamine or Razidine. They're antidepressant medications, selective serotonin reuptake inhibitors, things like Celexa, Zoloft, Lexapro, and antipsychotic medicines, Risperdal, Seroquel, Abilify. In medicine and in managing people in facilities, we generally don't like to use that last class of drugs. We're more likely to use the antidepressant simply because it can kind of modulate some of the symptoms. If people aren't sleeping, we may be able to put them on one of the antidepressants, and that makes it more likely that they will sleep. Not a sleeping pill, but one of those medications. The cholinesterase inhibitors and the NMDA antagonists are things that we also may add. And again, this doesn't cure the disease, but it may help with some of the behaviors. Next, please. One of the things that really does help people who have problems with confusion and can't remember things is to put them in a routine daily schedule of activity, excuse me. So if you do any caregiving training, whether you're with the Alzheimer's Association, with a support group, one of the things we like to stress is that older patients with dementia function well in a very structured environment. We get up at a certain time. We eat our meals at a certain time. We have set times for eating, drinking, toileting, socializing, and physical exercise. For people who wander at night, a lot of physical activity during the day, like getting them up, taking them for walks, riding bikes, swimming, whatever kind of physical exercise you do is something that helps get rid of all that extra energy they're trying to burn off when they're getting up in the middle of the night and walking around a lot. We like environments to stay the same, be consistent, same environment, same caregivers. Don't change caregivers all the time because that can be anxiety provoking and cause the patient being cared for to be uncomfortable because they don't recognize the new caregiver. Next, please. In summary, it's real important for you to understand that people's behaviors that are associated with dementia, wandering, repeating stories, urinating in improper places, is because a person's brain is not processing things the way you or I would. And acting or expecting them to act the way you or I would is something that will make you as a caregiver much more frustrated. When you see things that don't make sense, the best thing to do is to take that individual to the doctor to make sure that there is not something medical that may be causing that problem, whether it's an acute illness, whether it's a medication interaction, or maybe a progression in their dementia. That's something you need to discuss with a medical professional to just make sure that that's done. Medications that we use to manage some of the behaviors that I talked about a little bit earlier are varied, and in general, we don't like to put people who have dementia on medications just to control their behaviors, particularly medications that sedate and make it less likely that they will eat, that they will exercise, simply because that creates other medical problems. We like people to use behavioral strategies, establishing routines, setting routines that include bathing, grooming, feeding, and exercise, such that you can kind of like give them a schedule that they can follow, keeping them in a familiar environment and keeping them with a consistent caregiver such that they don't become anxious, fearful, and otherwise uncooperative. That's going to be the word that I use because family members use the word, she's not being cooperative. She's not being cooperative. She's not being cooperative because she doesn't really understand what's going on and she is fearful. And you need to address that. Thank you. Questions? I'll answer what's in the chat. You can go on to the next presenter.
Okay, thank you, Dr. Parker. Mary, I was wondering if you could come on really quickly because Dr. Parker mentioned that wandering is such an issue. And so I know that the Alzheimer's Association has a lot of strategies in place. And I was wondering if you could tell them about those.
Right. Well, I think one of the best strategies is to look for a program like Safe Return, because you know, you can get a bracelet or something that is not only for the person with a diagnosis, but their care partner. And I really like for these things to be done before they're needed. I think it's important to recognize that, because we know that wandering is one of the major symptoms as the disease progresses, that you might want to go ahead and think about that. I also like the Safe Return program, or a program like that, where you register, you fill out a form for the person with the diagnosis and their care partner. You put your other chronic, if you have other health issues, you can put that in, is because what if you're separated? As time goes by, usually the person with the diagnosis will feel very connected to their care partner and dependent on them, if not in early stages or in MCI, for to help sort of be someone who helps you remember what you're forgetting, or orients you and just provides some security. Later on would be the wandering. But what if you're separated? What if there's a car accident or, something like that? It doesn't have to be wandering. There can be many reasons why we're separated from our care partners, and something might happen. So it can be a medical thing as well as wandering. But if you'll call the helpline, we'll be glad to give you some referrals or companies that do that. We don't do that, but we, again, can guide you to companies that you can choose from. I think there comes a point in a disease progression where Dr. May and Dr. Monica can speak to this. Dr. Parker, I'm sorry. can speak to this. That's about just making sure that they're not alone. Doctors may prescribe unable to be alone at a certain point, and so that's another consideration in the wandering.
Okay, and there are two more questions about sundowning and statins. So Dr. Parker, would you address the statins?
Okay.
And
Okay, I'm gonna address the first one, which is sundowning, which kind of falls under the category of behaviors right now. Sundowning is what happens to people later on, usually in the late afternoon and early evening, where they get significantly confused. You know, their behavior changes. If they've been calm and serene and cooperative all day, a lot of times at 4 o'clock or 5 o'clock, people will, when the sun goes down, may vary in the winter versus the spring or the summer, but generally later on in the day, people become extremely agitated and irritable, and even more confused. Somebody said, is this a real phenomenon? It is a real phenomenon, but you can avoid that phenomenon by establishing a routine that you stick to. So at 4 o'clock or 5 o'clock in the afternoon, if you know that this is when this person starts to get agitated, you might want to start getting that person ready for bed, fixing their meals, giving them an evening walk, whatever is calming to them and makes it easier for them. Again, establishing a routine is something that helps you minimize the likelihood of any of the behaviors that we've talked about, including sundowning. That is a real thing. Okay, the next question is, do statins have the potential to cause dementia? No, statins, which are cholesterol lowering drugs, are actually protective. Okay, we talked about different types of dementia and Alzheimer's. If you've been on this talk before, you know that there are several different types of dementia. That's why we say Alzheimer's and related dementias. So there's Alzheimer's dementia, there's vascular dementia that is precipitated by having high blood pressure, diabetes, and high cholesterol, and being a tobacco user or a smoker. All of those are risk factors, certainly for vascular disease or blood vessel disease, such that you don't get good brain flow to your brain and other organs. But statins help eliminate and minimize cholesterol, which is one of the things that contributes to the development of vascular dementia. So we say that statin drugs that lower cholesterol, protect your brain from having things like strokes occur. It doesn't prevent Alzheimer's as such, but if you have been prescribed a statin drug, it's likely that that statin medication is going to keep you from developing a major stroke or a heart attack, which can be considerably more debilitating than having memory loss related to dementia alone. I don't see any other questions in the chat. Let's see what's on the Q&A. Okay. Are there any studies conducted using marijuana for patients in dementia who have dementia? The answer to the question is yes. I'm not exactly sure where all of those studies take place, but if you want to know where there's a cannabis study, you need to go to something called researchmatch.org and put in the information that you're looking for. I know here in the Department of Psychiatry, we are doing some studies that have to do with mood disorders and cannabis or marijuana, and that's in the Department of Psychiatry. We did talk about that. We had the psychiatrist on a couple of months ago to talk about that. Now, there's something in the chat that says, I've been described donepezil. Is that a good medication? Yes, it's a good medication from the standpoint of it's being approved by the Food and Drug Administration. It's been approved for use by persons who may have Alzheimer's or related dementia. So it is safe. It is a good medicine that has some efficacy, but it is not a drug that cures or treats Alzheimer's or any other type of dementia. So if you've been given donepezil, not knowing anything about your history, I would say that somebody gave that to you because you complained of having some kind of memory problem. I don't know what your evaluation was, but suffice it to say that as a clinician, I don't prescribe that medication unless I've done a thorough medical assessment to make sure that I know why that person's having a problem with their memory. Okay, and I've answered the question about statins. Statins do not cause Alzheimer's, they protect your brain. Okay, so Miss Mean says, my mom is starting to show signs of confusion at 86 years old. What may be a good medication to start for her to slow down the onset? The most important thing to do is if you're seeing symptoms you haven't seen before, make sure that it's not a problem that can be corrected. A lot of people who get confused and haven't been before usually have a medical reason. Maybe they're dehydrated. Maybe they've got an infection. Maybe their sugar levels or their glucose levels are too high. Before we start prescribing medications for anything, we like to make sure that we're prescribing medications that fit the problem. So if somebody's now confused and hasn't been before, it's important to establish that that person doesn't have a medical reason that can be treated that is causing those symptoms. You should never go to a doctor and just say, I need this antibiotic, I need this, I need that. You shouldn't be given a medication unless it's appropriate for the thing that's being treated.
Right. And it is possible to be diagnosed with early stage dementia at 86 years old. I mean, our risk increases as we age. So keep that in mind.
Again, that gets to why it's important to work with your doctor to make sure that you're getting an adequate and appropriate and timely diagnosis. You know,
Right.
Here in Georgia, we have about 100, maybe 500,000 people who actually have some type of dementia. We don't know what kind because they haven't been fully evaluated or assessed. And Mary brought up something. She said, you may have early. Well, when you say early Alzheimer's, for us in neurology and in medical circles, early Alzheimer's is Alzheimer's that occurs before the age of 65. Late Alzheimer's is Alzheimer's that becomes after the age of 65. Got to be careful about how we say early and late. You may have symptoms, and those symptoms may occur before 65. And if those symptoms come before 65 and they've been proven to be Alzheimer's, you can say early onset Alzheimer's. Late onset Alzheimer's are symptoms of confusion and dementia that we've been talking about that come after the age of 65. Now, when we say in conversation, a lot of times we say, well, my mother's starting to forget things, or she's getting lost sometimes. We may say that's early in the stage of the disease, whatever that is causing it. That may be early signs, the wandering, the confusion, the memory loss may be symptoms, early symptoms of an impending dementia, but they haven't gotten there yet. But keep in mind, early onset Alzheimer's is Alzheimer's before age 65. Late Alzheimer's, late onset Alzheimer's is Alzheimer's after 65. Symptoms of impending dementia are different. We have early signs that early on may indicate that somebody's starting to have a problem, like people who are repeatedly getting lost, people who are repeatedly having difficulty with their, what we call activities of daily living and instrumental activities of daily living. Those are diagnostic clues that there is something that's awry in the way that person's brain functions. What's causing it, we don't know yet because we haven't had an evaluation and we haven't gotten a diagnosis. So if you take away nothing from me today and Dr. Trammell and Miss Mary today, it's to discuss what you're observing and what you're seeing with your doctor so that you can get a comprehensive evaluation to understand better what might be driving the behaviors that you are observing. Let's see, I'll get to the questions in the chat.
Okay. Well, it is 3:04. Matt, I guess, was unable to join us. Crystal, I don't know if you have the CEP live link. Typically, Matt comes on and tells us what to expect at 3 o'clock during the cognitive empowerment programs live session typically follows our session, our BrainTalk Live session. So if you're able to access that link, you can drop it in the chat. All right, well, thank you all for joining us again this Tuesday. We've been doing this every Tuesday since March 31st of 2020. Our goal, though, is to transition to what we are referring to as a hybrid model. We are accustomed to seeing you in the flesh, in person. And because of the pandemic, we had to pivot, and now we're ready to resume in-person activities. We are in the planning stages, and so as those details unfold, we will share them with you. But for now, we will continue with our Tuesday sessions virtually, but we do anticipate hosting a concurrent session where you will see us on the camera, and if you want to join us in person, okay? If you are interested in joining us, you can raise your hand on the camera or give us a yes, or send me an email and just say, keep me posted, keep me informed. I miss seeing you. We miss you guys in person, and you'll get to see John in person as well, because we will be bringing him along with us to keep us active. And I hope you guys have gotten lots of physical activity tips, because he's been joining us for over a year, giving you those 8 to 10 minutes of exercise. So none of us have any excuse for being inactive during the pandemic, because he's given us so many tips. Okay, maybe he'll do a little dance, give us a dance move to learn as we begin to see you all in person. All right, Mr. Jim said, keep me on the list. I see a couple of hands raised, but yeah, we've got to get back to normal, right? That's where we are heading. All right, we miss you guys. We know it's important to stay active and be engaged. Dr. Parker?
My last little take home is we are a research center, and you will hear us talk about research. And we want you to participate in any of the studies that are going on here. Those people who had participated in our studies for aducanumab, for delaying memory progression or dementia progression, are the first ones in line to get the treatments that have been FDA approved. So being involved in clinical research here is an advantage for us. We learn what we think might work, is efficacious, but more importantly, if something comes around that we have that can be of benefit, you're going to learn about it first through research by participation. A lot of what we do in healthcare now came about as a result of research participation. And research doesn't necessarily mean that you're always sick. We're really studying healthy people and healthy aging right now through our Emory Healthy Aging study. And we've been talking about it before. It's a low hanging fruit for us. It's a low risk to you. Please participate in Emory Healthy Aging or any other clinical research that you want to participate in that you feel comfortable with. Thank you.
Okay. All right. With that, we will see you back here next Tuesday. I think you are going to hear from Dr. Lenora Higginbotham. She's going to be talking about dementia and MCI in a study that that has just come online. All right. Thank you guys for joining us. Goodbye, Mrs. Caldwell.